Today I'm going to talk about a very important subject, which is practically a household topic, and that is arthritis. Um, I suppose every household has this problem in one way or another, and it is universal. There are different kinds of arthritis, and it's often confusing for a physician how to approach a patient who comes in with arthritis. There's an overlap between arthritis and arthralgia. Arthralgia meaning pain in the joint without inflammation, while on the other hand, arthritis is the actual inflammation of the joints. So uh, before you start in any patient, it's very important to observe when the patient walks over to you in a clinic. See if the patient is limping, if the patient is in agony, pain, how the patient is moving, how the patient is holding his or her belongings, and when the patient sits down. So the diagnosis of arthritis, in fact, starts by observation, and then you take a history and physical examination. And there's, as I said, I mean, there's often an overlap between monoarthritis and polyarthritis. A lot of patients confuse one joint from another. They may not be able to tell you exactly if the joints are tender, painful, swollen, but they'll just say that they are in pain. And for any person who's been in pain because of joint problems, they are often depressed as well, and so therefore they'll try to tell you as much as they can in the shortest possible time, and we want some kind of remedy from you. So arthritis basically means that there are four things which are being fulfilled. One of them is dollar. Second is rubor. Third is tumor, and lastly is calor. Rubor means the joint should be red. Tumor means the joint swollen. Calor means the joint should be tender. And dolor means the joint should be hot. So the joint has to be hot, it has to be tender, it has to be swollen, and it has to look red. And if these four criteria are fulfilled, then the patient has got arthritis and not arthralgia. So the arthritis generally is of two kinds. One of them is monoarthritis and the other one is polyarthritis. Mono means one joint, poly means several joints. So you have to ask clearly if the patient has problems with one joint or more, and then forward questioning whether there is really arthritis or just pain as such. In patients who've got polyarthritis, there are three possibilities that the patient may have. Now, these are the patients who come in with pain and tenderness and swelling of the metacarpophalangeal joints or the proximal interphalangeal joints or the toes, or they can have problems with the knee and the hip simultaneously along with the elbow. So they can have polyarthritis, may or may not be symmetrical, and that's something which you will elicit on the history. But if they come with polyarthritis, there are three possibilities. One of them is that they have got rheumatoid arthritis. The second is that they have got SLE or connective tissue diseases. And the third one is that they have got gout as a third one. Gout is a great mimicker. It can mimic anything. It can cause monoarthritis and can cause polyarthritis. So these are the three possibilities. There will be several others, but these are the ones which cover approximately about 90% of all patients who come to you with genuine arthritis. If somebody comes with monoarthritis, once again, there are three possibilities. One of them is osteoarthritis. The second one is trauma. And the third one is gout and sepsis. The reason I've said gout and sepsis is because gouty arthritis is as exquisitely tender as septic arthritis, and often they overlap unless you go into the joint and take the sonography out for examination. And that's why I put gout and sepsis under the same heading. So if somebody's got problems with the knee, for instance, or the hip, you think of one of these three possibilities. And if they've got multiple joints which are involved, symmetrical or asymmetrical, then these are the three things to look out for. Once you've taken the history, you've done the examination, in which it's very important how you touch and how you feel the joints. Remember, these patients have got very painful joints, and if you're not very careful, you will cause significant discomfort. So, very important that how you touch these patients. Once you've examined the joints and you've confirmed that yes, you are dealing with arthritis, not just arthralgia, the three investigations that you're going to do, initial three investigations, one if of them is CBC and a CRP. You can also request an ESR, in fact, in certain situations. For instance, with SLE, ESR is more important compared to CRP. In septic arthritis, CRP is more important. All in all, the value of CRP is more compared to ESR. The second investigation, which obviously you will do, is going to be a uric acid level. Although uric acid levels are often normal in people who have an acute attack of gout, but nonetheless, uric acid levels may be normal or high normal, but they're often not low in cases of acute gout. And the third one that you'll do is going to be an RF factor. The RF factor will tell you whether or not the person has got seropositive or seronegative arthritis, and so therefore an RF factor is very important. So these are the three basic tests, these are three basic investigations. Now, what if the person has got either polyarthralgia or monoarthralgia? The patient has got multiple joints, but they are not inflamed. They do not follow this pattern. That means dollar, rubor, tumor, or calor, but they've got pain all over the joints. Now, these are the patients who've got polyarthralgias. And there are several causes for that. But in general, if they've got problems with weakness, there are joint pains, there is stiffness in the morning, but they're not really swollen, and especially if they've got some tender points, and these patients have got polymyalgia rheumatica. Polymyalgia rheumatica, in fact, is a pretty underdiagnosed condition. It's common if you look out for it. So polymyalgia rheumatica can overlap fibromyalgia. In case of fibromyalgia, we know that there are certain people who are more predisposed to having fibromyalgia, but you don't get tender points. In polymyalgia rheumatica, you will get tender points, especially the wrists. The wrists are going to be tender, so there will be tender points where you touch, especially the shoulders. The shoulders are going to be weak. Patient may find it difficult to wear clothes or perhaps comb their hair. So movement with the anti-gravity muscles is going to be difficult. There'll be weakness, there'll be fatigue, there may be muscle wasting, and there will be tender points either here or here. And these are the patients who've got polymyalgia rheumatica. Be on the lookout for. So, in a nutshell, monoarthritis, polyarthritis, make sure you're dealing with arthritis. If there is monoarthritis, one of these three are the possibilities. Is there osteoarthritis, there is trauma, or the gout or sepsis. You don't have to go into the fourth or fifth or the sixth one. These are the commonest ones. And these are the three tests which you'll do initially, and then you can ask for other tests afterwards. If there is polyarthritis, whether they've got involvement of symmetrical or asymmetrical, metacarpophalangeal joints, proximal interphalangeal joints, or asymmetrical arthritis, these are the three possibilities. There can be gout, SLE, or other different connective tissue diseases, or for instance, mixed connective tissue disease, or there will be rheumatoid arthritis. Thank you.